Best practice in outpatient hysteroscopy. Green Top Guideline number 59. March 2011. Background. The procedure involves the use of miniaturized endoscopic equipment to directly visualize and examine the uterine cavity without the need for formal theater facilities or general or regional anesthesia. Outpatient hysteroscopy is indicated primarily in the assessment of women with abnormal uterine bleeding, but is also employed in the diagnostic workup of reproductive problems. More recently, advances in endoscopic technology and ancillary instrumentation have facilitated the development of operative hysteroscopic procedures in an outpatient setting with or without the use of local anesthesia. Common procedures include endometrial polypectomy, removal of small submucous fibroids, endometrial ablation, removal of lost intrauterine devices, and transcervical sterilization. Outpatient hysteroscopy, whether diagnostic or operative, is successful, safe, and well tolerated. However, as with any procedure requiring instrumentation of the uterus, outpatient hysteroscopy can be associated with significant pain, anxiety, and embarrassment. This not only impacts upon women's satisfaction with their experience, but also limits the feasibility and possibly the safety, accuracy, and effectiveness of the procedure. To minimize pain and discomfort, variations in hysteroscopic equipment, adaptations to the technique, and use of pharmacological agents have been advocated. Service provision. What is the ideal setting for performing hysteroscopy? All gynecology units should provide a dedicated outpatient hysteroscopy service to aid management of women with abnormal uterine bleeding. There are clinical and economic benefits associated with this type of service. Outpatient hysteroscopy should be conducted outside of the formal operating theater setting in an appropriately sized, equipped, and staffed treatment room with adjoining, private changing facilities, and toilet. Clinical benefits of outpatient hysteroscopy: rapid mobilization post-operatively, quicker recovery to pre-operative levels, and high and equivalent levels of women's satisfaction. Economic benefits of outpatient hysteroscopy: less time off work, and reduced loss of income and reduced travel cost. What are the requirements for running an effective outpatient hysteroscopy service? Outpatient hysteroscopy should be performed in an appropriately sized and fully equipped treatment room. This may be a dedicated hysteroscopy suite or a multi-purpose facility. The healthcare professional should have the necessary skills and expertise to carry out hysteroscopy. There should be a nurse chaperone regardless of the gender of the clinician. Written patient information should be provided before the appointment, and consent for the procedure should be taken. Outpatient hysteroscopy can be associated with substantial anxiety, so the treatment room should be private and patient-friendly with a separate and ideally adjoining changing area with a toilet. Adequate resuscitation facilities should be available, as should a comfortable recovery area with refreshment-making facilities. Access to on-site or off-site decontamination facilities of an appropriate standard is necessary. Outpatient hysteroscopy should not be performed in a formal operating theater setting because this environment is likely to provoke anxiety in the women and negate the economic advantages associated with avoiding use of expensive operating theaters. Appropriate staffing levels are required. This will vary according to local circumstances and the type of service offered. When possible, one of the staff members should act as the woman's advocate during the procedure to provide reassurance, explanation, and support. Communication with the women in this way may help alleviate anxiety and divert their attention, thereby minimizing pain and embarrassment, the so-called vocal local. Adequate, clear, and simple written patient information should be provided with the appointment letter. Where simultaneous treatments are offered, it is important that this fact is reflected in the patient literature to facilitate informed choice. It is good clinical practice to obtain formal consent for outpatient hysteroscopy before the procedure. Analgesia. Do analgesics given before diagnostic hysteroscopy reduce the pain felt by women during the procedure? Routine use of opiate analgesia before outpatient hysteroscopy should be avoided as it may cause adverse effects. Women without contraindications should be advised to consider taking standard doses of non-steroidal anti-inflammatory agents or NSAIDs around 1 hour before their scheduled outpatient hysteroscopy appointment with the aim of reducing pain in the immediate post-operative period. Optimal timing depends upon the agent use, on their half-life, rate of absorption, and etc., and the route of administration, but in general simple, non-opioid analgesics given orally, such as 1,000 milligrams of paracetamol or 400 milligrams of ibuprofen, should be taken around 1 hour before the scheduled appointment time. Thus, it is likely to be more practical to advise women to take simple analgesics in advance of their appointment rather than administer them in hospital. This approach is likely to be of more benefit in those units offering simultaneous hysteroscopic diagnosis and treatment, for example, the See and Treat clinic, where the levels of discomfort experienced are likely to be increased. Cervical preparation. The cervical preparation reduces uterine trauma, failure to access the uterine cavity, or pain associated with outpatient hysteroscopy. Routine cervical preparation before outpatient hysteroscopy should not be used in the absence of any evidence of benefit in terms of reduction of pain, rates of failure, or uterine trauma. Uterine trauma or the lacerations to the cervix or uterine perforation is recognized with blind and endoscopic instrumentation of the uterus with an estimated perforation incidence of 0.002 to 1.7%. The incidence of uterine trauma is low for diagnostic outpatient hysteroscopy performed with small diameter endoscope, outer sheet diameter under 5.5 millimeters, under direct vision. Factors associated with uterine trauma include the need for blind dilatation, cervical stenosis, such as atrophy, cervical surgery, previous cesarean section, and nulliparity, a tortuous cervical canal, for example in association with fibroids, and a deviated uterine cavity, such as acute flexion, pelvic adhesions, and fibroids. Prostaglandins are associated with gastrointestinal adverse effects and are contraindicated in severe uncontrolled asthma, chronic adrenal failure, acute porphyria, renal or hepatic impairment, and breastfeeding. The main reason for failure to successfully perform an outpatient hysteroscopy is inability to access the uterine cavity as a result of cervical stenosis. This is most commonly encountered in the postmenopausal population. Two randomized controlled trials have assessed the feasibility of outpatient hysteroscopy after vaginal prostaglandins, and a meta-analysis showed no reduction in failure rates. Type of hysteroscope. What size and angle of hysteroscope should be used in the outpatient setting? Miniature hysteroscopes 2.7 mm with a 3 to 3.5 mm sheath should be used for diagnostic outpatient hysteroscopy as they significantly reduce the discomfort experienced by the women. There is insufficient evidence to recommend 0-degree or 4-oblique optical lenses, for example, 12 degrees, 25 degrees, or 30 degrees offset lenses for routine outpatient hysteroscopy. Choice of hysteroscope should be left to the discretion of the operator. Offset lenses offer a wider field of view, a property that can be advantageous in visualizing the corneal recesses and tubal ostia within the uterine cavity with minimal external movement of the hysteroscope. 4-oblique lenses facilitate a visualization of ancillary instrumentation and so are advantageous for operative hysteroscopy. However, zero-degree hysteroscopes are more intuitive, facilitating entry into the uterine cavity through the cervical canal, which may reduce the need for cervical dilatation as well as minimizing discomfort and uterine trauma. Should rigid or flexible hysteroscopes be used routinely in the outpatient setting? Flexible hysteroscopes are associated with less pain during outpatient hysteroscopy compared with rigid hysteroscopes. However, rigid hysteroscopes may provide better images, fewer failed procedures, quicker examination time, and reduced cost. Thus, there is insufficient evidence to recommend preferential use of rigid or flexible hysteroscopes for diagnostic outpatient procedures. Choice of hysteroscope should be left to the discretion of the operator. Distension medium. Which uterine distension medium should be used during outpatient hysteroscopy? For routine outpatient hysteroscopy, the choice of distension medium between carbon dioxide and normal saline should be left to the discretion of the operator, as neither is superior in reducing pain, although uterine distension with normal saline appears to reduce the incidence of vasovagal episodes. Uterine distension with normal saline allows improved image quality and allows outpatient diagnostic hysteroscopy to be completed more quickly compared with carbon dioxide. Operative outpatient hysteroscopy using bipolar electrosurgery requires the use of normal saline to act as both the distension and conducting medium. Does the type of distension medium affect pain experience during outpatient hysteroscopy? The meta-analysis showed there to be no significant difference between the pain experience with the use of carbon dioxide versus normal saline for outpatient hysteroscopy. Uterine distension pressures need to be sufficient to allow systematic inspection of the entire uterine cavity. However, care is needed to ensure that pressures are minimized to avoid overdistension of the uterus and consequent pain. Which distension medium produces the best image quality during outpatient hysteroscopy? Normal saline produces lavage of the cavity and so washes away any blood or mucus which otherwise might obscure the view. Carbon dioxide may produce bubbles and bleeding, leading to unsatisfactory view. Which distension medium should be used for operative procedures? Normal saline should be used as a distension medium when bipolar intrauterine equipment is used for hysteroscopic surgery. Thus, it is more practical to perform diagnostic procedures with normal saline in units offering simultaneous diagnosis and treatment, as this avoids having to swap distension media should operative procedures need to be carried out. Hysteroscopic sterilization requires fluid distension medium. The choice of normal saline or glycine depends upon the specific technology adopted. Local anesthesia and cervical dilatation. Should routine dilatation of the cervical canal be used before insertion of the hysteroscope in an outpatient setting? Blind cervical dilatation to facilitate insertion of the miniature outpatient hysteroscope is unnecessary in the majority of procedures. Routine cervical dilatation is associated with pain, vasovagal reactions, and uterine trauma and should be avoided. Cervical dilatation generally requires administration of local cervical anesthesia. Standard protocols regarding the type, maximum dosage, and route of administration of anesthesia should be developed and implemented to help both recognize and prevent rare but potentially serious adverse effects resulting from systemic vascular absorption. Blind dilatation of the cervix to instrument the uterine cavity is commonly performed under general anesthesia and is associated with cervical and uterine trauma. In addition, in the conscious women, dilatation of the cervix causes pain and discomfort and generally requires the use of local anesthesia. Should topical local anesthetic be administered before outpatient hysteroscopy? Installation of local anesthetic into the cervical canal does not reduce pain during diagnostic outpatient hysteroscopy, but may reduce the incidence of vasovagal reactions. Topical application of local anesthetic to the ectocervix should be considered where application of a cervical tenaculum is necessary. Should injectable local anesthetic be administered to the cervix and/or paracervix before outpatient hysteroscopy? Application of local anesthetic into or around the cervix is associated with a reduction of the pain experienced during outpatient diagnostic hysteroscopy. However, it is unclear how clinically significant this reduction in pain is. Consideration should be given to the routine administration of intracervical or paracervical local anesthetic, particularly in postmenopausal women. Miniaturization of hysteroscopes and increasing use of vaginoscopic technique may diminish any advantage of intracervical or paracervical anesthesia. Routine administration of intracervical or paracervical local anesthetic should be used where larger diameter hysteroscopes are being employed, with an outer diameter greater than 5 mm, and where the need for cervical dilatation is anticipated, for example, cervical stenosis. Routine administration of intracervical or paracervical local anesthetic is not indicated to reduce the incidence of vasovagal reactions. Conscious sedation. Should conscious sedation be used to reduce pain associated with outpatient hysteroscopic procedures? Conscious sedation should not be routinely used in outpatient hysteroscopic procedures as it confers no advantage in terms of pain control and the woman's satisfaction over local anesthesia. Life-threatening complications can result from the use of conscious sedation. Appropriate monitoring and staff skills are mandatory if procedures are to be undertaken using conscious sedation. Sedative drugs such as anesthetics, anxiolytics, and opioids are administered by oral, intravenous, transmucosal, or inhalational routes. Any drug that depresses the central nervous system has the potential to impair respiration, circulation, or both. Close monitoring of the woman must be undertaken by a designated staff member to ensure maintenance of continuous verbal contact and adequate oxygen saturation. Monitoring of blood pressure and electrocardiogram should be considered in high-risk cases, and staff trained in acute airway management and anesthetic support should be immediately available. Vaginoscopy. Thus, a vaginoscopic approach to outpatient hysteroscopy reduce pain and increase the feasibility of the procedure. Vaginoscopy reduces pain during diagnostic rigid outpatient hysteroscopy. Vaginoscopy should be the standard technique for outpatient hysteroscopy, especially where successful insertion of a vaginal speculum is anticipated to be difficult and where blind endometrial biopsy is not required. Vaginoscopy, or the no-touch approach to hysteroscopy, refers to a technique where the hysteroscope is introduced into the vagina through the cervical canal and into the uterine cavity without the need for vaginal speculum or cervical instrumentation. In a systematic review, vaginoscopy was associated with significantly less procedural pain. Vaginoscopy allows increased external movement of the hysteroscope. Appendix number 1. Terminology. Conscious sedation. Conscious sedation refers to an arousable but drowsy state in which a woman can communicate and maintain an airway. Sedation techniques aim to make potentially unpleasant interventions more acceptable. However, there is potential for the drugs to impair respiration, circulation, or both. This dictates that the operator should have advanced training in airway management and anesthesia. Direct intracervical, cervical anesthesia. Local anesthetic is injected directly into the cervix, intracervical or direct cervical block. The anesthetic solution should be distributed equally to all cervical quadrants. The majority of the anesthetic should be injected at the deepest possible point in each quadrant, with some distributed evenly along the length of the cervix as the needle is withdrawn. Outpatient hysteroscopy, office or ambulatory. The term outpatient hysteroscopy encompasses office and ambulatory hysteroscopy. Paracervical anesthesia. Local anesthetic is injected into vaginal mucosa at the cervico-vaginal junction. 1 to 2 milliliters of anesthetic is injected to produce swelling and blanching of the tissue around the cervix. The needle is then advanced into the vaginal vault and the anesthetic is delivered to a depth of 1 to 2.5 centimeter. Care should be taken to aspirate before injection to avoid inadvertent intravascular injection. The injection site may be tracked by injecting as the needle progresses. The standard bilateral injections are at the 4 o'clock and 8 o'clock positions, although 3 o'clock and 9 o'clock positions are often used. Procedural pain. For the purpose of this guideline, procedural pain is defined as an overall global assessment of pain associated with outpatient hysteroscopy. If a global score was not given, the pain experienced during inspection of the cavity was used. Topical anesthesia or transcervical. Anesthetic gels such as Instilla gel, which contain lidocaine hydrochloride of 2% and chlorhexidine gluconate solution of 0.25%, creams such as EMLA, which contains lidocaine 2.5% and prilocaine 2.5%, or sprays such as xylocaine or lidocaine 10% are applied to the ectocervix, cervical canal, or into the uterine cavity. Absorption through mucous membranes may be slow and unreliable, so sufficient time should be allowed for the anesthetic to work. Vaginoscopy. The vaginoscopic or no-touch technique involves introducing the hysteroscope into the vagina without a speculum or cervical instrumentation. The labia minora are then held close and the table tilted backwards to keep the distension medium inside the vagina. The hysteroscope is slowly advanced to visualize the cervix and identify the cervical os. The scope then traverses the cervical canal and passes into the uterine cavity. Vasovagal reaction. Vasovagal reactions are caused by stimulation of the parasympathetic nervous system. The cervix receives parasympathetic innervation from the sacral nerves. Manipulation and dilatation of the cervix can lead to stimulation of the parasympathetic nervous system, which causes hypotension and bradycardia and causes women to feel sick and faint. They may display clinical signs such as pallor, sweating, and reduced conscious state. Most women will recover rapidly if the procedure is stopped and instruments removed and they are put in supine or recovery position. Cool fanning, fluids, and reassurance will hasten recovery. In rare cases, atropine may need to be given.